Hi again. We are going to move on to Chapter 8, where we get into fetal circulation and talk about how that's all affected. It's the fetal circulation. The fetus is all enclosed. It has its own circulation, supports the respiratory system, supports the nervous system, supports perfusion, all inside the mother's uterus. The placenta provides everything, protection, exchange of all the nutrients, oxygen that the fetus needs, dependent on the mother's good health, good circulation. So we're going to move on to Chapter 8. Look at your calendar because there are some skills and some activities there. I will be posting some more activities for you to look at to help reinforce the material. This week we'll also be going to the hospital for some orientation. And those of you who will be going to Cabrini for clinical will also be going to the hospital for some hospital orientation. And then next week you'll be in the hospital delivering patient care. So hopefully this will help give you a little bit of insight, and we'll be progressing on. Okay, I'm going to share my screen with you again so that you can have my slides. So give me a moment. Okay, so now we're talking about Chapter 8. Let me get this going where you can actually see it. And we'll be talking about fetal circulation, the physical and psychological changes of pregnancy. And I'll be giving you some handouts. I'm looking for some that will be very easy for you to learn and for you to understand. Okay, so what are some of these changes that happen in pregnancy? What happens? You'll be reading a lot and we'll be talking a lot about the hormonal changes. So what I will tell you is, for sure, read up on estrogen and progesterone. What happens with each one of them? What happens when they increase? What does it do to the woman's body? What about some of the other hormones in the woman's body? What happens with those? And we'll talk about a few of them. So in the uterus, there are increased amounts of estrogen as well as the growing fetus. The uterus will increase in size. It's going to increase in weight, length, width, depth, volume, and the overall capacity. Because we start off with just a little pear-shaped uterus, and then all of a sudden it grows large enough to hold a fetus inside. It goes from pear-shaped to ovoid shape. Look up what a Hagar sign is and see if you can figure that out. We have enhanced uterine contractility, and for the uterus to get accustomed to contracting and what that feels like, we call that Braxton-Hicks contractions, where the contractions happen just on the sides of the uterus. It doesn't really affect opening of the cervix for the baby to be born. It's just little practice contractions. The uterus will ascend into the abdomen from the lower parts of the pelvis after the first 3 months. And the fundal height by 20 weeks gestation should be at the level of the umbilicus. So this is usually a very reliable determination of how many weeks gestation she is until she reaches 36 weeks. We'll talk about fundal heights, where we measure from the symphysis pubis to where we feel the top of the uterus. That's called the fundus. And if she's 20 weeks gestation, that measurement should be equal to about 20 centimeters. And if it's different than that, there could be a lot of reasons for that, but that's usually whenever she goes to the healthcare provider, that's one of the things that we'll do is measure a fundal height. The cervix and vagina have increased estrogen levels. Estrogen is responsible for hyperplasia. Hyperplasia is an increase in cells. There will be a formation of the mucus plug, and the mucus plug is what prevents organisms from ascending into the uterus or going up into the uterus. The vaginal area is very warm, and it's a very moist area, and that place is often a good culprit for yeast infections and other types of infections, so the mucus plug helps to keep infection out. There is a softening that occurs in the cervix. Is called the Goodell's sign, and this is from the increase in estrogen. And the increase in vascularization is called the Shadwick sign. It's a bluish color, and that is from the increase in estrogen. The ripening of the cervix occurs usually about 4 weeks before birth, and this is for normal birth. It starts getting softer, it starts getting ready to dilate for the birth of the baby. The vagina has increased vascularity with thickening. It lengthens because it has to lengthen the vaginal vault to prepare for childbirth. The secretions become more acidic in this area to prevent infection, and they're white and it's thick, and this is called leukorrhea. There's also a relaxation of the connective tissues that occurs from the progesterone that will cause a relaxation of the tissues. For the breast, the increase in the estrogen and progesterone cause an increase in the size and the number of mammary glands because the breasts are getting ready to breastfeed the baby. The nipples become more erectile and the areola will become more dark. And colostrum, or the foremilk, will become available during the 3rd trimester. And this colostrum is very rich yellow fluid that is good to help the baby with its immunity. And we don't want mama practicing expressing this, but it can be expressed around the 12th week of gestation. And it does convert to mature milk after the baby is delivered. The respiratory system, the increased levels of progesterone causes increased volume of air, decreased airway resistance, and increase in the anterior posterior diameter, because progesterone causes a relaxation of the mom's muscles so that she can stretch and move and that uterus can grow. Her lungs will be able to have an increase in the volume of air, and there's a decrease in the airway resistance because there's more room, and there's a more, her chest is becoming more round and a bigger diameter, so her lungs have more room to expand. So you'll notice she will be breathing more thoracically as the uterus enlarges because her lungs are getting squished. So there's an increase in the diaphragmatic excursion in the chest circumference and the tidal volume. There's an increase in oxygen consumption because mother is consuming oxygen, and she's consuming enough oxygen for she and the fetus. Oftentimes there's a congestion, nasal congestion, that happens secondary to increase in the vascularity. That's because of the increased estrogen. And so her nose will feel like it's stopped up. Sometimes she'll even have nosebleeds. So here's an image for you showing all the organs that get pushed up, the stomach gets compressed, and the bladder gets compressed. So you can see why oftentimes mother has indigestion quite often, because her stomach is pushed up and she has to feel like she has to go to the bathroom quite often because her bladder is compressed. So with the cardiovascular system, and this is kind of detailed, so you might want to read in your book so you can understand it a little bit better. With the increasing level of estrogen and progesterone, the cardiac output and the volume, blood volume increases, because I'm producing and I'm increasing my cardiac output, because I not only have to have a good cardiac output for myself, I have to perfuse the fetus. So my cardiac output and blood volume is going to increase by 50%. And this is for someone who has a normal cardiac function. The increased size of the uterus will interfere with blood return from the lower extremities, and the increased level of red blood cells, because we need to increase the oxygen delivery to the cells for the developing fetus. So with this decreased blood return and this increase in the blood volume and the increased level of red cells, the clotting factors are going to increase. So pregnancy is a hypercoagulable state, and we'll talk about that quite often in measures that moms have to do to help prevent the development of blood clots. The increase in the output is going to decrease the venous return from the extremities, and she may have an increased heart rate. Sometimes there's a slight decline in the blood pressure until mid-pregnancy because of all of this cardiovascular volume, increased cardiac output. Everything is trying to get balanced out. There's an increased number of red blood cells, and so the plasma volume is higher. And sometimes this causes a hemodilution, making us think that she's anemic, but really it's a physiological anemia because the red blood cells are more diluted, and it's not that she is really iron deficient. So it's important that you know the difference between physiological anemia and iron deficiency anemia. Because of the developing fetus, there's an increase in the iron demands. The fibrin and the plasma levels are higher. That's why we said that she is in a hypercoagulable state, running the risk of blood clots. Some of the clotting factors have increased. So it's very important that we pay close attention to all of these things. So here's a good side-by-side that I put together for you so that you have a pretty good idea of what's going on. With the GI and the GU system, increasing levels of progesterone will make the gums more hyperemic, swollen. This is why she needs to use a soft toothbrush when brushing her teeth. Talism, she'll look like she's drooling sometimes. She may have dental problems, so we always tell moms whenever they first get pregnant, go to the dentist, make sure your teeth are good. It's not that pregnancy will make her teeth bad, it's just that the baby is going to get everything it needs. So if mom's teeth are bad and she doesn't practice good hygiene, sometimes moms have a lot of vomiting, and that can really cause some issues with if she already has dental caries or problems with teeth or gums. In the GI system, the increased levels of progesterone will cause a decrease in the peristalsis and smooth muscle relaxation. Because of the decrease in peristalsis, we're in the risk of developing constipation. Increased venous pressure and pressure from the uterus can also run the risk of her developing hemorrhoids. The slow gastric emptying may cause her to have heartburn and reflux. The prolonged gallbladder emptying, sometimes I've seen some moms end up developing gallstones. And plus also there is the oftentimes nausea and vomiting, and sometimes it gets pretty intense and she may develop a hyperemesis. For the GI system, the increased blood volume, the glomerular filtration rate will increase. Her renal tubular reabsorption will increase. And sometimes there is a dilation of the renal pelvis and elongation of those. And the developing fetus may put pressure on those ureters, and it may cause a hydronephrosis where the kidney gets enlarged because urine is getting backed up into the kidneys. The increased glomerular filtration rate normally will cause an increased urine flow and volume. So whenever moms are lying down, oftentimes they'll have to get up and go to the bathroom quite often. And women oftentimes need to lay on their sides because laying on their back is very hard to breathe. So then the developing fetus will put more weight on the ureters, making her need to go to the bathroom. So for the mom's skin and hair, musculoskeletal system, and central nervous system, the skin pigmentation, sometimes we'll have little skin pigments that come up on our face, and that's due to increase in the estrogen and progesterone. The hyperpigmentation is also often called the mask of pregnancy. It's called melasma. Linea nigra, I will have a picture to show you. It's the dark line that goes down the middle of her belly. Striae gravidarum, those are stretch marks that happen because our skin stretches everywhere, and those do not go away. Varicosities from the weight of the developing fetus. Some women more than others may end up developing varicosities in their legs especially, or vascular spiders. Palmar erythema is because of the increase in the blood flow and the cardiac output. The inside of her palms may turn red. Her hair oftentimes will decrease in growing for a little while and increase in the nail growth, and all that has to do with the increase of the estrogen and progesterone in the body and how it affects those different areas. Musculoskeletal, the joints are relaxed, and that's from the estrogen and progesterone to soften and stretch the ligaments, especially in the sacroiliac joints, because that's the area that needs to move and stretch for the baby to be born. Postural changes happen. That's why you see these moms walking with a sway back to center the center of gravity, especially the larger they get. They'll have a forward shift of their center of gravity so they won't fall. And they'll have an increased lordosis, a lumbar spinal curve, to help them balance their gait. You'll see them waddling kind of like a duck sometimes. The central nervous system, and this all has to do with the hormones and the increase of the hormones and everything going on. Oftentimes she may find herself having a decreased attention span or decreased ability to be attentive and remember things. She's got a lot going on. So here's a picture of the linea nigra. It's just a darkening line that goes down the center of the abdomen of pregnant women. So metabolism and the weight gain. This is something that a lot of women worry about. And it's important that if we can, during prenatal care, we talk to her about weight gain and make sure that she's not withholding nutrition to keep from gaining weight. Metabolism does increase during pregnancy, and because this is the demands of the growing fetus is going to get what it needs, and it needs its nutrition to support the growth and development of all the systems. Recommended weight gain is 25 to 35 pounds. If she is pregnant and she's already overweight, Usually the recommended weight is 15. If she's underweight, she may gain all the way up to 40 pounds. If she's a healthy weight, if she's at a BMI of like 25 to 35, and that's not supposed to be, her first trimester, she could gain between 3.5 to 5 pounds. In the second and third trimesters, about a pound a week. If her BMI is lower, below 19.8, she can gain 28 to 40 pounds. During the first trimester, about 5, and then second, third trimesters, a little bit more than a pound a week if her BMI is a little lower. If her BMI is over 25, she's usually considered overweight, and we really don't want her to gain more than 25 pounds if she can help it. First trimester, about 2 pounds. Second, third trimester, no more than 2 to 3 pounds a week. And this is to help her as well as helping the developing fetus. So for the thyroid, often there's a slight enlargement, increase in the activity of the thyroid, increasing in the basal metabolic rate. The pituitary gland enlarges. There's a decrease in the TSH hormone and the gonadotropin hormone. The FSH, the follicle stimulating and the luteinizing hormone, there's an inhibition there, and the reason being is because she's not ovulating right now, so there's no need for these two hormones to be released. There is, however, an increase in the prolactin because she's getting ready to lactate, and there's a gradual increase in oxytocin with the fetal maturation because she's going to need the oxytocin later on for contractions and for her uterus to clamp down after the baby is delivered. For the adrenals, there's an increase in the cortisol and aldosterone secretion, and the pancreas, and this is another reason why we pay attention to the weight gain. There is an insulin resistance due to the I never can remember the HP, but it's a lactogen and other hormones in the second half of the pregnancy that causes an insulin resistance because the fetus is requiring glucose. And we don't want the insulin metabolizing all the glucose so that the fetus can't get it for its development. So, we have a little insulin resistance during the second half of pregnancy so that the baby is getting enough glucose for development. Now, we'll talk all about diabetes and all of that later on this semester. This is for a normal pregnancy. Okay, we're going to continue on with the presumptive signs of pregnancy, the probable signs, and the positive signs. And I will go ahead and tell you now, the only positive sign we have is an ultrasound verification that she is pregnant, because we can do blood tests, we can do have symptoms and those types of things that we might feel like she's probably pregnant, but without a positive ultrasound within 4 to 6 weeks to actually see an embryo, that's the positive sign. Presumptive or subjective signs, these are experienced or reported, and these can also be caused by something else. And these often, if they're experienced without any other signs, that's why we call them presumptive. And these are not proof of pregnancy. She may be complaining of fatigue, breast tenderness, nausea, vomiting, amenorrhea, that means she's not having a period right now, urinary frequency, and quickening. And all of these things can be caused by other things besides just pregnancy. Some hormonal. Urinary frequency can also be caused by UTI. Quickening, sometimes that can be caused just from her having gas and feeling like something's moving around in her belly. Probable signs are objective. These are things that a healthcare provider can see, but these could also have other causes as well. These aren't proof of pregnancy, like Braxton Hicks contractions, a positive pregnancy test. Sometimes because of a human choriogonadotropin is high, that can be high because of something else. There's molar pregnancies that we'll talk about later in the semester that can have a positive pregnancy test and she's not really pregnant. Abdominal enlargement, bloatment. Bloatment is when an examiner can perform an exam and push up on what they feel like is the baby's head, and the baby's head drops back down. They feel that could be caused from a tumor or some other fibroid tumor, some other issue. A positive Goodell sign, a positive Chadwick sign, a positive Hagar sign. Those things, while they are signs that we look for in pregnancy, if they occur alone without any other symptoms, they could be caused by other things, other hormonal things. Or even a uterine souffle, if we listen and we think we hear a swishing sound in the uterus, if there are no other signs apparent, that could be caused from something else. So the positive signs of pregnancy, as I said, ultrasound verification at 4 to 6 week gestation, fetal movement that is felt by an experienced clinician that usually can't occur till about 20 weeks. The mom is not really feeling fetal movement right then, but the clinician can. Or auscultation of fetal heart tones with a Doppler. Usually we can't hear it with a Doppler until she's at least 10 to 12 weeks gestation. All right, so here is another table in your book that also gives you some of these subjective changes and what some of the alternative causes may be. And that's a good little chart for you to review over. All right, so the presence of Hagar sign, this is the softening of the isthmus of the uterus, and this felt by a healthcare provider doing an exam, and they feel that the uterine area, you can see where the cervix is and where the isthmus is feeling more soft than how it normally feels on a regular exam. So here is a chart of the objective signs of pregnancy that I had told you could also be caused by other things if these are symptoms that are happening without the presence of other things. All right, so pregnancy tests, I'm not going to spend a whole lot of time because oftentimes these pregnancy tests change, but there are different kinds. The one that we're all familiar with is the serum blood test or an over-the-counter pregnancy test that you can purchase now. And most of those, the over-the-counters are urine tests. Oftentimes these are used by healthcare providers along with to back it up with a serum test. The urine tests will usually give immediate results and will detect HCG or human chorionic gonadotropin, and this can be detected in early pregnancy. There are also radioimmunoassay serum tests that will be done. These are often used to help detect if there's an ectopic pregnancy or trophoblastic disease. Trophoblastic disease is whenever the HCG is high and you think that she might be pregnant, but it's not a true pregnancy. The HCG is extremely high, and she may have what we term as a molar pregnancy that we'll talk more about later in the semester. And the ELISA serum test, it can detect HCG as early as 7 to 9 days after ovulation and conception, and as early as 5 days before the first missed period. And the FIA takes about 2 to 3 hours, but this would be one that we might order for someone that may be having some issues or an abnormal, some abnormal pregnancy test. Over the counter or a enzyme immunoassay test, urine, they're very sensitive, they're very effective, but she must really follow the instructions carefully. And if she hadn't had a period in about a week, it can be repeated again. My suggestion to moms is always, if you take an over-the-counter and you're not getting a result and you're feeling not so good, it's always best to go to your doctor. Let them go ahead and do a serum so that you're making sure you aren't having some behaviors that might not be good if you are pregnant. Emotional and psychological changes. These things happen. They start happening very quickly. During the first trimester, she's still trying to get used to the fact that she's just found out she's pregnant. So she may be not believing it real quick. Because you can't really see the signs of pregnancy yet. And so she's a little bit ambivalent, not really sure how to feel, especially if she wasn't planning on getting pregnant or wasn't prepared. Second trimester, starting to feel the baby move. So this helps mom to know a little bit about, she can identify now the fetus is becoming to be part of her because she's seeing the signs and she's feeling that baby move around. Third semester, trimester, I'm stuck on semesters, aren't I? The third trimester, she's a little anxious about the labor and the birth because it's getting time to get that nursery ready. We call that nesting. And she has bursts of energy because she's getting all excited. She can breathe really well because that baby's moving down. And she's a little anxious, so not quite sure what to expect. So the Rubens 4 psychological tasks of the mother, it's her job. She feels like it's her job to ensure safe passage through the pregnancy and the labor and the birth of this new one. And she wants this baby to be accepted by everyone. And she doesn't want anybody to say anything bad about it. And she's wanting to feel like that she's going to be a good mother, and she wants commitment and acceptance of herself as a mom of a new baby. My daughter-in-law, she wants to feel like she's going to be able to be a good mother, and she wants to take care of this baby. She's not wanting so much extra help right now. And you're starting to learn to give of yourself more because you've got this little one to take care of now. The father, we can't forget about him. He's got a very strong role too. And oftentimes, because we're so focused on the mom, a lot of times the father feels left out. And he's having a hard time believing everything too. This is all very new. And mom's moods are changing. She's up and down on a roller coaster, and he might get very confused about her mood changes. And some dads, sometimes they resent all the attention she's getting and he's not getting any. So we can't forget about them. We have to include them in. And I'm talking about mothers and fathers, but we also have to include partners here because we have non-traditional families as well. And we have to treat them all the same. They're still a family. During the second trimester, oftentimes the dad or the partner is starting to decide what behaviors they want to either imitate from one of their parents or ones they want to discard and develop their own. And by the third trimester, they're sharing with the mom. They're getting a little anxious. It's getting real, and it's getting time for the baby to come. Kuvad, this is a new term. This is whenever the male develops physical symptoms of pregnancy. Mom is fatigued, dad is fatigued. Mama starts having aches, dad has aches. Mom has an increased appetite, daddy will. Daddy shares the same symptoms that mom is going through, is what is called Kuvad. Siblings, we can't forget about them either. It's important that we talk to the parents or talk to the couple and find out, if you have siblings, how do you want them involved? What's important? What are their ages? Because there's a new baby coming home. Some younger siblings don't handle this very well. So sometimes they view this as a threat. Something else is going to get mom's and dad's attention and not me. So we've got to take care of those two. Both hospitals used to have sibling classes where we could bring the siblings in and help them learn about the new baby, see where mom's going to be, and it helps them develop a little bit better expectation of when that new baby's coming. And of course, this is all dependent on the age of the siblings, and preparing them for the new one coming in is essential so that they won't feel left out. It's very important. And it's important also, if you have younger ones, get somebody to come in and help take care of the new baby so that the mama can also spend time with the siblings as well. That's very important. Grandparents are usually very supportive. They're usually very excited. They're often very unsure on how they should become involved. Some grandparents have some overly high expectations of how much they should be involved. So it's very important to help young parents know it's okay to set boundaries, and it's okay to talk these things through so that people won't be acting the way they're not supposed to act, and they won't be jumping in where they're not really wanted. So this is very important. All right, so culture. We have to know a little bit about how we feel about different cultures before we can be really good advocates for our clients. We have a very diverse area now here in Alexandria and some of the hospitals where you all will be working. And so it's important for us to take an inventory of ourselves so that we can take really good care of our laboring mothers and take care of our families. So we want to do a really good cultural assessment, because there are some things that are perfectly safe for other cultures to do that we can help to make their experience a lot more comfortable for them. So our assessment, what are their main beliefs? What are their wishes for this delivery? Any type of family traditions that we need to talk about to make sure it's safe for mother and baby. And if it is safe, it's okay. What are their values about childbirth? How do they feel about childbirth? And what are some behaviors about pregnancy and childbearing that are very important for us to know? Hopefully this discussion has started with a healthcare provider, but if it has not, it's important that we as nurses taking care of them during the labor process while we're doing our assessments, that we try to explore this. So if we do this, we know what she's expecting and what type of family support she has, and what type of family support she's going to need. And we can be responsive to everyone, and we don't want to make them feel like that we are controlling their experience with their new baby. So some of the factors that will impact are their religious preferences, their language, the communication style, some of their practices, their ethnic background, of course, and any affiliation they have with ethnic group. any spiritual needs that they have. We know that religion and spirituality are two different things, and one's culture is often sometimes different, what their beliefs are and what their support system is they prefer to have. We need to be free and open to talk about these things, and the only way that we can be free and open to talk about these things is if we've taken a good self-assessment ourselves. As I've said earlier, we will have non-traditional families. Family is not always the mom and the dad, as many of us are accustomed to. Families can be two women, two men with a surrogate. We support all of them, and we advocate for them, as we want them all to have the best experience that they can, because we're there to care for them and care for their new baby. And we want to establish a good, safe environment for all of them. Okay, well, these are the lectures that we will go over for our first week, just getting a good introduction, getting our feet wet. And if you should have any questions, please feel free to let me know. Okay, we'll see you soon.